Good morning, everyone. I'm Director for the Texas Health Institute and co-lead for the Texas Primary Care Consortium. It's an honor to welcome everyone for today's webinar, Exploring Health Innovations in Rural Texas. For today's webinar, it's an honor for me to moderate and invite two amazing panelists and experts on rural health in Texas, Dr. Adrienne Billings, a Chief Medical Officer with Preventive Care Health Services, FQHC, and Dr. Kia Parsi, Executive Director at the Texas A&M Rural and Community Health Institute. I really look forward to hearing from both of them and engaging in a discussion to advance health and healthcare in rural Texas. As part of today's webinar, our hope was to use this next 60 minutes to help all of us create a shared understanding around the current landscape of health in rural Texas. Hopefully lift up a few real-world examples that demonstrate successful innovations and leadership in healthcare access in rural Texas. And in doing so, identify some short-term and long-term strategies that will benefit rural Texas. Again, thank you for joining us. For those of you who are familiar, hopefully the next few slides will serve as a reminder, but was pleased to see that we have several new colleagues and friends joining us on today's webinar. And for those of you new, Texas Primary Care Consortium is a statewide collaborative initiative with a mission to advance equitable, comprehensive, and sustainable primary care for all Texans. It's an effort that is co-led by Texas Health Institute and the Texas Medical Home Initiative. As part of our work as the statewide primary care consortium, we lead with this framework, again, as a neutral convener. Such as this webinar, we identify many opportunities during the year to lift up best practices, innovations, and create spaces for shared learning and growth. Also, as part of serving as your consortium, we leverage our role as a neutral convener to facilitate our opportunities that build and strengthen lasting partnerships for shared and sustainable impact. And as part of our work at a state level, it's primarily through statewide consensus panel, we engage in advancing policy or systemic changes that advance high quality primary care for all Texans. Of course, all of this work is possible as a result of support and partnership for many organizations out there. Just lifting up the few organizations and partners who support all of our efforts, particularly this webinar. We want to thank or share our appreciation for Episcopal Health Foundation, St. David's Foundation, Texas Academy of Family Physicians, the Texas Association of Health Plans, TMF Health Quality Institute, and United Healthcare Community Plan. I also want to share that I have an opportunity to represent an amazing team on today's webinar, but really it takes a team to bring everything to you as part of our role as the Primary Care Consortium. And I just want to recognize the amazing team that allows us to do this every day. So to contextualize today's discussion, and since we have two amazing experts, I want to keep my talking points limited to a few, hopefully just to contextualize the discussion today and recognize the background why we approach this from a point of innovation. This slide and map is not something that's new to many of us who engage in different spaces to advance health and opportunity in rural Texas. But it's important to recognize that if primary care shortage area was a concern leading through the pandemic or in the pre-pandemic space, that need has only multiplied since the pandemic, as the two maps can demonstrate. The one with more white dots is in 2019, which did indicate need, but there were some opportunities of some counties across the state not being identified as a shortage area, and the map with pretty much a darker shade of blue across the board, we see immense gaps when it comes to primary care access and overall health professional shortage across the state. Also, it's important to recognize that as a state, we do have across the board the highest uninsured rate in the country, and a large burden of that is concentrated in our rural communities across the state. There are many outcomes as a result of this gap and this chronic challenge. One of the things that we have heard, read in newspapers, articles, op-eds is the state leading the country in rural hospital closures, about 26 of them since 2010. Again, it leads to a whole new set of needs and opportunities along the way if we take a step back and look at it from a systems viewpoint, but the uninsured rate is a key contributing factor. However, again, as a Texas Health Institute, as a public health organization, and coming into this conversation as a co-lead for the Primary Care Consortium, our approach to this work is delivering health and healthcare in rural is not just an attribute of our capacity as a healthcare system, or what healthcare system could be doing in meeting these gaps, because health is a result of a multitude of factors and outcomes outside of the traditional healthcare boundaries, economic, educational, and social aspects. I personally have been a fan of the Area Deprivation Index, which is a composite score of a multitude of factors. And if you really take the urban cores or spots from this map of Texas on this screen, we really have a very gloomy landscape. Some of the darkest shade of red, which indicates an area with the highest deprivation index score, are really the most rural pockets in our state. So as we navigate through this landscape, delivering health or healthcare in rural communities is not just about finding solutions within healthcare, but in doing so, how the solutions are addressing some of the gaps and barriers in many of the other systems or factors that yield poor health outcomes. As such, the two things that matter most is leadership perseverance and innovation to finding those solutions and finding pathways that can deliver sustainable and impactful healthcare for all rural Texans. So with that, again, that is a broader context as part of bringing us to today's discussion. Now it's my honor to both invite, welcome, and introduce our two amazing experts and speakers for today's webinar. First, I'll go with Dr. Adrian Billings. As I shared earlier, he serves as the Chief Medical Officer for Preventative Care Health Services at QHC in the Big Bend area. Alongside, he also serves as the Associate Academic Dean of Rural and Community Engagement and as a Senior Fellow for the Mary Hall Institute for Rural and Community Health at Texas Tech University Health Sciences Center. Dr. Billings has been a career-long rural community physician and along the rural Texas-Mexico border of West Texas. He currently serves as an elected school board trustee for Rural Alpine Independent School District, as well as an officer in the Texas Academy of Family Physicians, and is on the board of the Association of Clinicians for the Underserved. In a recent conversation I had with Dr. Billings, and that's part of what he does and what brings him to today's discussion is his lifelong commitment to advancing opportunities for rural-born and educated students to enroll them in healthcare training programs and workforce. So with that, Dr. Billings, the floor is yours.
Muy buenos días. Thank you so much for that very generous introduction. I am very excited to be here and learn with you all today, and I want to thank you all for the privilege of your time this morning. Let me just make sure that I'm getting into presentation view. Okay, so this slide is really to help remind me that really this story that I'm about to share in the next 10 or so minutes is really about a term that Paul Farmer Accompaniment uses, the accompaniment of a federally qualified health center, a rural FQHC with an academic health center. This slide also reminds me that as rural residents, we wear many hats, whether you're a physician or a clinician, or you're just a rural resident member. So I do serve and wear several hats, and I'll be talking mainly about my role with the FQHC, but also with Texas Tech Health Science Center today. Just as some advocacy for National Rural Health Day, just want to put this on everyone's radar. There is a day every day that is set aside by the National Organization of State Offices of Rural Health to celebrate and advocate for more rural healthcare access. And that is National Rural Health Day, and it is this Thursday, November 21st, 2024. I challenge you all to be a part of National Rural Health Day events and or to put on your own events. I spoke to some medical students this weekend at a Texas Academy Family Physician meeting, and that was my charge to them. We will be having an event in Odessa, and so you're all welcome to attend, and please reach out to share more. And I can share more. So getting into some of the innovations, the things that we have tried to do with Texas Tech Health Science Center include these rural family medicine residency programs that are currently in 6 locations, Alpine, which I am most involved with, but also in Fort Stockton, Sweetwater, Beckles, and now Carlsbad and Hobbs, New Mexico are the newest rural residency programs to come on board. Fort Stockton has been the longest serving rural residency program, and they've been the most successful at retaining their graduates. These residency programs were formed in communities of need that have chronically struggled with both physician recruitment, but also retention as well. These are all at critical access hospitals in communities The smallest one is in Alpine, 6,000 population, to up to 10 to 12,000 population in some of these other communities. They are all what we call 1+2 programs. The interns, the first-year residents, spend their first year in Odessa in a resourced quaternary care hospital, medical center hospital, or Midland Memorial Hospital, and within a resourced academic health center clinic setting. But then they come and they are trained in the under-resourced settings of the rural healthcare environment in both a critical access hospital and, in Alpine's case, a rural federally qualified health center. And significantly, our Alpine residents, 1 day a week, each of them goes down to our Presidio location right on the Mexican border, 180-mile round trip commute for them to provide really cradle to grave outpatient care at the Presidio location. Texas Tech is also the recipient of a HRSA Center of Excellence grant. The aim of this grant is really to increase family physicians in West Texas. The FQHC has been a beneficiary of these trainees coming out and rotating with us within the FQHCs to get some rural medicine exposure. But really, part of this is really partnering with the Area Health Education Center program to outreach to middle school, high school students to plant the seed of the way that they can serve their communities as considering going into healthcare. And we get into the pre-med programs as well at universities in the West Texas area. And of course, we use this as a track for support of our Family Medicine Accelerated Track program, trying to recruit some of these pre-med students into the 3-year Family Medicine Accelerated Track program, which is a 3-year medical school versus the usual rural 4-year medical school. Emphasis on this grant is really all about rural exposure, in the sense that we're trying to get these students out, these medical students and these resident physicians out to our rural communities to serve rurally and to be trained rurally as well. This has led to our National Rural Health Day events that we have put on for the past 2 years. And newly that we put on was a multi-institutional, multidisciplinary rural healthcare summer camp for rural high school students at Sul Ross State University this past June. We're also the recipient, the FQHC is, of another Texas Tech grant, a behavioral health workforce education training grant from HRSA. The aim of this is to increase behavioral health workforce in West Texas. And the scope of this grant is to really give some stipends to support to master's degree seeking licensed professional counselor students enrolled at Sul Ross State University in Alpine and the University of Texas at El Paso. The emphasis of this is really care of vulnerable population. And the goal of this is retention of these students into LPC associate positions and growth to rural sites. And we have been successful. We were able to roll over one of our BWET students who graduated from Sul Ross to stand up as a LPC associate in her hometown of Pecos at Reeves Regional Medical Center. So the needs of rural Texas are not just a physician, not just a nurse, but really multidisciplinary in nature, as evidenced by these 2 grants that are at the Texas Tech PA program in Midland, also from the Bureau of Health Workforce. These 2 grants are increased rural and rural behavioral health PA workforce in West Texas, and this provides some stipend support to Texas Tech physicians assistant students for both rural primary care and behavioral health rotations longitudinally and for a prolonged period of time. Again, the emphasis of this grant, as is the others, care of these rural and vulnerable populations. And the goal is retention of these PA graduates into the rural sites. And in fact, we were able to host several of these PA students, and one of them that has just graduated, we have offered her a position, and she starts in October at the FQHC in the Big Bend. The other big emphasis of TTUHSC is this Institute of Telehealth and Digital Innovation. The aim of this institute, which is supported by the state legislature, is to really leverage digital technologies to expand access to those underserved areas. And the scope is, again, multidisciplinary. It is both pre-hospital with some EMS ambulance telehealth support in primary care, behavioral health care, telehealth provision, as well as some school-based telehealth clinics that we're working to operationalize in the West Texas region. And the emphasis of this institute is really healthcare access through innovation. And the goal is to bridge the barriers in the 108 county Texas Tech service area of West Texas to expand access into our most remote rural areas. So this is really my dream slide. This is really the solutions that are as of yet needed. As was said, I have a bias for rural students as I was a rural student, and I've raised three children that have been rural publicly educated, and I serve as a school board trustee for rural school districts. I want to propose, and I hope I don't need to convince any of you all, that rural students are an under-resourced and underrepresented population within our healthcare training programs. But they are our solution to solving our rural healthcare workforce. But we just need to invest in them and enable them and give them an opportunity to serve their home communities or similar rural communities. A nice new development from the Texas legislature and the Texas Education Administration that is going to serve rural students is the Rural Pathway Excellence Partnership Program, which allows rural school districts with limited resources and limited students and limited faculty. It allows them to share some higher education dual credit training programs, such as certified nursing assistant programs or EMT programs, and some other non-healthcare related things. But this will help to grow the rural health workforce of tomorrow. Advocate for a development of a rural admissions medical program that is very much analogous to the joint admissions medical program, which was started by the state legislature in the early 2000s to provide mentoring support for socioeconomically disadvantaged students within Texas higher education institutions, providing them with mentorship as pre-med students, mentorship for their MCAT, their medical college admissions test, prep courses and scholarship support, and then mentoring them when they are in medical school and giving them a little bit of a lower threshold of MCAT scoring and GPAs to be a successful matriculant into medical school. And I envision a rural admissions medical program very similar, but focusing on rural students, providing them with mentoring in higher education, mentoring for their MCAT prep courses, and then mentoring them while they're in medical school, and then getting them back home or a rural community during their clinical clerkships and possibly for residency as well. I also want to advocate for more pathway programs from the associate degree healthcare training programs all the way to the terminal MD and or DO granting healthcare training programs. I feel that we need to advocate for more pathway programs for rural students into our healthcare training programs. Again, they are our solution to the rural healthcare workforce with some investment in them, and they are academically at a disadvantage to going into higher education, including into medical school, because of the academic challenges that rural schools have of providing advanced placement courses. Many of our rural schools do not offer advanced placement courses, and there are virtually zero international baccalaureate programs at rural schools. So when these students are competing for entrance to medical school, they are competing with urban educated students that have all of those resources that are not available to them in a rural community. But what these rural students bring is this sense of community, this sense of commitment, this diverse background that they've had from showing livestock to serving their communities and volunteering and playing multiple sports and marching in the band at halftime. And so they bring what we need in community healthcare providers, those that are community oriented. We need to additionally do more to enable rural rotations for all of our healthcare training program students. We need to raise some of these students in rural community-based settings away from our academic health centers. Rural communities have incredible training opportunities to provide our rural students, and most of our healthcare training students are hungry to have that rural community exposure. I also want to advocate for the establishment of a multi-institutional, multidisciplinary rural academic health center or centers throughout our state. Most of our healthcare training programs are in urban areas, and I think we need to do better to train these students in rural areas, both pre-clinically and just do distance education back to the urban campus, but especially clinically at trying to grow our own rurally. I want to introduce, this is my last slide. I just want to introduce this term of clinical courage, which is something that's come out of the Australian and Canadian rural medical literature 15 to 20 years ago. But it really describes what it takes to have the fortitude to serve rurally. And I would love to, I wish we could give an infusion of this clinical courage to all of our healthcare training students. And I think we can, but I think they have to go to a rural area to witness the clinical courage from our rural clinicians to be able to stand up outside of your normal scope of clinical guidelines to provide essential care to patients. For these students to see what's them going beyond usual and into uncharted territory to manage a patient in the best way possible. To demonstrate to these healthcare training students, clinicians have to be adaptable and willingness to work at the limits of their training to experience and meet the needs of their patients. And to have that mental fortitude to stand up again, day in and day out in an under-resourced environment to serve the needs of their communities, to essentially have this sense of purpose, mission, and calling, the sense of, if not me to serve this rural community, then who? Thank you very much.
Dr. Billings, again, real inspiring in terms of the way you approach this and the difference you make. And I really am at this moment, like with that last slide on courage, 100% agree, but it's also a wonderful segue into the other part of our discussion with Dr. Kia Parsi. So as I said, a segue is because part of it is like we need to do more to bring in more physicians and healthcare workforce in our rural communities and in the rural settings, and we need to make sure that the opportunities in the broader environment is conducive for them to continue doing so. But we can't unless and until we start addressing and have a broader systems look and address some of those systemic barriers. So with that, it's now my honor to introduce Dr. Kia Parsi. He currently serves as the Executive Director for the Texas A&M Rural and Community Health Institute, also serves as the Associate Professor and Executive Director for the Texas A&M School of Medicine Rural Program. Dr. Parsi brings a breadth of experience. First, over 2 decades of experience as a clinician, working in a wide variety of settings in rural communities, be it FQHCs, fee-for-service clinics to hospitals and long-term care. In addition, Dr. Parsi has extensive experience as a physician leader and in a part of executive leadership teams, both serving as a chief medical officer and an interim CEO for an integrated healthcare system that included 3 critical access hospitals, 2 acute care hospitals, 2 nursing homes, and over 30 ambulatory clinics. Again, Dr. Parsi brings this unique perspective, both as a clinician, being in settings, but also being on the system side of making healthcare and healthcare delivery in rural Texas and communities or operationalizing that story. So Dr. Parsi, truly honored to have you on this webinar and look forward to hearing more about the efforts you're currently leading through Texas A&M Rural and Community Health Institute.
Well, thank you, Ankit. And I will just say that presentation by my esteemed colleague, Dr. Billings, was very inspirational. Especially the last few slides. And I really like the point where he, time and again, shared with exposure, rural exposure. You take a look at this slide in front of you, that's a beautiful sunset. And there is so much that we can appreciate and thank related to our rural communities. There are between 3 and 4 million Texans living in rural communities, more than any other state in the country. But there are specific and unique challenges in providing rural health care. Residents in rural areas face health disparities rooted in economic, social, racial, ethnic, and geographical factors. So Compounding this, rural Texas residents can face significant challenges accessing preventive, acute, maternal, and chronic care services. So, along with Dr. Billings, I would like to say that we really appreciate the Texas Primary Care Consortium providing the time for us to present our programs, and Texas Tech is doing an excellent job in helping to expand the ability to have our workforce and quality care in rural communities. So I'm going to talk a little bit about a program that we're doing at Texas A&M called the Rural Engagement Program, or TexREP for short. What is TexREP? So TexREP is a program that was funded by the legislature, the last legislative session. So the services that are being provided are at no cost for the rural healthcare institutions that we're supporting. And it is aligning resources between the institute that I'm the executive director of, the Texas A&M Rural and Community Health Institute, along with the School of Medicine, School of Nursing, and we're starting to work with the School of Pharmacy and the School of Dentistry. And we wanted to take a look and identify what are the ways we can support rural healthcare in Texas as an academic institution, as a land-grant institution. And we came up with two main focuses. First is workforce. And Dr. Billings talked a lot about workforce as well, but how through education, experience, and upscaling can we help increase the workforce capacity in our rural communities? That's the first. The second was, how do we keep our rural healthcare institutions open and viable? Ankit mentioned that Texas leads the nation in the number of rural hospitals that have closed in the last 10 years. So how do we expand how do we expand business support services for our rural hospitals and rural facilities so they can stay open, they can expand, they can provide healthcare, and they can use the workforce that we're trying to grow and develop? So this pyramid that you can see in front of you talks about the different components of TexREP. And the foundation is workforce. And how does the School of Medicine, the School of Nursing, and the other schools within the Texas A&M Health Science Center help expand workforce in rural communities? I'm going to talk a little bit about the programs that both the School of Medicine and the School of Nursing are implementing to do that. On top of that is, again, the ability to support the viability of rural institutions, and that's where my institute comes in. I'm going to talk a little bit about some of the different types of services and technical assistance that Archie can provide, as well as working with the Texas A&M Telehealth Institute and other capabilities to expand services in rural communities, as well as expanding the traditional residency programs, similar to what Texas Tech is doing, as well as long-term viability. So how do we keep hospitals and clinics open today in the rural setting? But how can we also plan on keeping them open in the future with value-based care, alternative payment models? How can we provide that assistance for rural institutions that often don't have the bandwidth to know what are the next steps to stay open and viable? And the goal, of course, is to improve healthcare in our rural communities and grow and expand what we're able to do. Talking a little bit about the rural medicine program, and Dr. Billings, I think, had some great points. Again, exposure, exposure, exposure. How can we expose our students? Many of them are from urban settings to the rural environment so they can understand what it's like and maybe consider that as a future career opportunity. So we've created rural immersion electives, 2 weeks to 4 weeks electives, and we've partnered with the rural communities. So we don't want our students just to learn what it's like to care for heart failure in a rural setting. We want our students to know what it's like to live as a rural clinician, what it's like to live in those communities. So we create community stakeholder teams, and these are leaders in the local community, and they help us with the agenda, with the schedule for these students. So not only are they working in the clinic, in the emergency room, in the FQHC, in the ER, or the hospital inpatient setting, but they're also going to Friday night football games. They're going to Rotary Club meetings. They're going to potluck dinners so they can experience the rural community. And also, as Dr. Bellingson mentioned, the most likely person to work in a rural setting is someone from a rural setting. So how can we continue to support the local independent school districts to let those students consider healthcare as a future career opportunity? So we have some K through 12 programs that we're growing and developing as well. And something that I'm excited that we're going to work on this next year is what we're calling a community APGAR project. So this is actually was implemented University of Idaho and University of North Dakota, who also have very robust rural programs, to evaluate rural healthcare institutions that are trying to recruit physicians or nurses or CEOs. How does that community stack up compared to other communities? So we'll be working on that project this next year. Again, the goal is exposure. And how can we have these students consider working in rural areas? This is a real student, Caleb Hostler, to your right. He was an NMED student. So Texas A&M has an engineering medicine program. And you wouldn't think an engineering medicine graduate would be considering rural. Well, Caleb did, because he had the opportunity to experience a rural rotation. He got to see a mentor in Dr. Robinson, who's pictured there at Goodall Witcher in Clifton, Texas. And Caleb said when he left that rotation and he was driving out away from that community, driving back home, he looked back and he said, I could live here. So providing that exposure for our students to consider living and working in rural areas can be very powerful and impactful for our students. Just want to mention this next year will be our second annual Rural Practitioners Conference. Dr. Billings was able to participate in the last one. Hopefully, he might be willing to speak at this next one. I need to grab him and ask him if he's willing to. So if you're a practitioner, a physician, nurse practitioner, nurse midwife, physician assistant, any other kind of practitioner, there's a conference that we're holding the end of March in Fredericksburg, which is rural, but a destination point. So just keep that in mind, and there'll be further communication about that as well. Talking about nursing. So workforce, physicians, there's a shortage, huge shortage with nursing. So the Texas A&M School of Nursing, now College of Nursing, has a number of different programs that are within this TexRep initiative, which again is funded by the Texas legislature to provide scholarships for students that are considering working in rural settings, or individuals who are already working in rural settings and want to upskill. So a BSN to become an MSN, MSN to become a nurse practitioner. The school is providing scholarships for those nurses and upscaling where they can still work in their rural setting, but advance their career. The College of Nursing is also revamping their curriculum to make sure that there's a rural focus for the nursing students to, again, consider rural as an opportunity for them. And there are a number of nurse-led initiatives, including an RHC with a mobile unit that it will be, has been and will continue to provide care in rural settings, including rural ISDs, and telehealth initiatives, again, as an opportunity to expand the kind of healthcare that's being provided in rural communities. So we talked about workforce, now the technical side. How do we help keep these rural institutions open and viable? And that's a big part of what our institute is working on. And there are a number of different ways that we're trying to support the viability of rural hospitals and clinics. A lot of it's related to financial performance, but again, value-based care or alternative payment models. How will they be ready for the future of healthcare payment systems? We talked about workforce, but also service lines. How can rural institutions expand what they are currently providing in a way that is financially sustainable for them? Marketing and communication. So we work with outside vendors to help rural institutions to really market what they can do, and they can all provide high quality care, but make that known to the community that they're serving. And we also provide monthly webinars with different experts on related specialties and areas of interest Again, these are all funded by the state legislature. This last year was the first year of TexRep, and these are some of the programs that we provided. We worked on a Medicare Advantage community education project. What does Medicare Advantage mean in the rural setting, especially for critical access hospitals? Most beneficiaries don't know the challenging effects of Medicare Advantage on the rural hospital setting. So we're helping with a communication program for the rural hospitals to communicate that with their rural communities. We worked on a Just Culture project where rural hospitals can develop a patient safety organization so they can confidentially try to improve the quality of care that they are providing in their institutions. Working on patient experience, we have an outside consultant that we worked with to help rural hospitals with their patient experience initiatives. Financial improvement opportunities. There are so many ways that rural hospitals can optimize their performance, and they're not always doing it. How can they improve their cost report, their charge master? Has it been updated? We have rural hospitals that haven't updated their charge master in 10 to 15 years. Coding and billing, and a number of different financial related opportunities to make sure these hospitals can be as viable as possible. So there are a number of different types of initiatives that we're working on with technical assistance. Here is a map of the state of Texas. It's a huge map. So all the academic land-grant institutions have a place to work and support rural healthcare. This lists the number of counties that are at some way or another, the healthcare institutions in those counties are getting assistance through our TexRep program. Now, I mentioned value-based care. Luckily, FQHCs and RHCs this last year, starting calendar 2024, can do some of these additional types of supportive services, such as chronic care management, remote patient monitoring. These can be a foundation for future population health initiatives in rural communities. And so we are providing some technical support to help these rural institutions move forward with some of these other initiatives as well. This is my last slide. This is if any of you are interested in receiving the technical assistance or want to consider a workforce opportunities with this College of Medicine and College of Nursing, we have here an inquiry form that you can go to that link, fill out the form. Someone from our team will meet with you, talk with you about what your needs are. Maybe have a virtual on-site planning session to see how we can assist you in providing the excellent care that can be provided in our rural setting. I'm going to stop sharing here, Ankit, my slides.
So thank you, Dr. Parsi, again. Every time I hear your presentation, I learn something new. And again, appreciate everything that you and your team have been doing since we are yet to get to that 1 year mark since you officially were funded. So a distance well traveled, and appreciate all the leadership and ways you have been helping our rural communities. Dr. Parsi, I really appreciated you sharing what's been happening, but I would love to get a couple of minutes to hear your thoughts on what we need more of. Or as you look at it forward and we approach our next legislative session and opportunities thereof, what are things from your experiences so far that we need to be thinking about?
Well, the entire list that Dr. Bellings provided at the end, I support every one of them, and very creative suggestions to help with workforce. There are other opportunities. Maternal care in rural settings. We talked about the number of hospital closures. In addition, there is a large number of rural hospitals that may stay open that have decreased maternal care services. So we have a high percentage of maternal care deserts. These are counties in Texas, rural counties, many of them, that don't have any obstetrical care. So I think that would be an important consideration for the next legislature. They made some huge, with House Bill 12, improvements in funding. But I think there are additional things that we can work on as well. And again, that list that Dr. Bellings had to expand the opportunities for our rural population students to consider healthcare as a future career, but then also how can we expand for the entire healthcare academic setting? Most of our medical students are from urban areas. How can we expose them with increased number of 2+1 rural residencies and other rural exposure opportunities?
Thanks, Dr. Parsi. Dr. Billings, I'm going to invite you to come back on so that we can have a discussion. Again, I'm honored to have this opportunity. I do have a couple of questions for both of you, but seeing the engagement and all the reactions in our audience, I do want to welcome and invite those of you joining us on today's webinar to use the Q&A box for sending in your questions. I already see about 4 of them. Seem interesting. I'm going to lift up a few, not going in one particular order, but just to piggyback on Dr. Parsi, your response, which I think is a very welcome change or perspective. That one question is, again, looking at next legislative session, how can we be engaging more of our urban counterparts or those of us in urban settings, physicians? I would extend to say not just physicians, but anyone who is an advocate for a healthy state and healthy community. What can we be doing to supporting the work you all are already doing, but where we need more investments and support for? And the question is for both of you, whoever prefers or is comfortable going first.
I can certainly start, and I want to highlight Dr. Parsi's and Texas A&M's Rural Practitioners of Texas Conference. I would love to return. It was an amazing conference last year, so I would want to extend that welcome to everybody as well. An amazing conference. So I think rural healthcare, we want accompaniment. Our rural patients deserve, our rural students deserve, our rural healthcare systems, they have earned accompaniment by our academic health centers, by our larger urban healthcare institutions. I think most of us in the rural healthcare space, we have the humility to understand we do not have all the resources nor the knowledge that our patients have earned and that they deserve. And it's only through collaboration, partnership, the sense of accompaniment that we can expand service. We at the very least, we have to sustain what is already existing. And in my dream world, we can grow the rural healthcare system if we roll up our sleeves and we have hope and we have faith, but we're willing to invest and put the sweat equity needed into building up the rural healthcare system. We can do that. I think just from my perspective, I don't think one academic institution can meet the needs of rural Texas. We have to be, I think, as Dr. Parsi and I are demonstrating right now, we have to be collaborating together in partnership as a team. To use another Paul Farmer, forgive me for, he was one of my virtual mentors who I admired his work. One of his quotes was, "Our most significant professional accomplishments in life are done in partnership as a team." We have to be collaborating together. We, just as individually, I have strengths and weaknesses personally, probably more weaknesses than strengths. Also, as a clinician, I have strengths and weaknesses. So do our academic institutions, that we can, if we can work together, we can build up each other's weaknesses and feed off each other's strengths. So I really do believe that this is a creation of a consortium of academic institutions from the community college level all the way to the academic health center to try and meet the needs of rural Texas is a way moving forward.
Yeah, I'm not sure what more I could add to what Dr. Billings said. One thing to consider, the amount of funds and resources that we are spending on rural healthcare compared to our urban settings is really minuscule. So any additional funds that we're providing in the rural healthcare setting is really a small piece of the amount of dollars that is currently being spent at the Medicaid, Medicare, the state and federal level. So increasing that to some extent for our rural settings, I think, is very important. Rural hospitals, they're in a crunch right now with the growth of Medicare Advantage. I expect, unless we make some changes, to see a large number of closures over the next 10 years with the growth of Medicare Advantage, because it changes the reimbursement structure for critical access hospitals. So that's more of a federal discussion, but I think it's an important one to keep top of mind as well.
Absolutely. Dr. Parsi, just to piggyback on that comment, but specific to the program Archie's leading, there is a question about, are there opportunities for primary care rural rotations for NP students?
Oh, yeah, that's a great question. I feel for our nurse practitioner students because often they are burdened with trying to identify a clinical training site. And we actually just started with the School of Nursing for Texas A&M for the nurse practitioner program to make sure we have a list where they can identify potential rural sites for nurse practitioner students to consider doing rotations. So it's a big challenge. Luckily, Texas is also a big state, and there are a lot of rural FQHCs, RHCs, clinics out there with highly competent, capable nurse practitioners who have worked for dozens of years in the rural setting. And many of them would be willing to teach the next generation of nurse practitioner students. So yeah, I'd be happy to try to work with nurse practitioner students on identifying opportunities in the rural setting.
I again keep the questions coming, but I'm seeing a few. We'll try to cover all of them, but just again, like going back to the way I started this discussion, you show or paint a map, and we use the description rural Texas, but rural Texas is not a monolithic construct. Like, it's very different for those of them, or when we are talking about rural in the valley or rural in East Texas and up in the Panhandle. So I want to lift up this particular question that as a result of that, the demographic makeup is very different when you're trying to really bridge and meet the needs of our rural residents. Any particular initiatives you both are aware of, or your institutions are a part of, that specifically address language barriers, or even cultural considerations, if I may say, culturally appropriate care delivery in these settings? Again, the question is from someone who is a bilingual nurse and has found this to be an asset. Again, any thoughts?
I'm happy to answer. Thank you for that question. And that is often why I begin with muy buenos días or muy buenas tardes, to highlight some of the need for Spanish speaking. We have a significant population throughout our country, especially in Texas, that is Spanish speaking only. And too often, our healthcare training workforce is not Spanish speaking as well. And that's our second highest need language to communicate in Texas is Spanish. And that has been a recruitment and a retention barrier for us in the Big Bend. My practice in Presidio is about 80% Spanish speaking only. And had I not grown up in Del Rio and made a committed effort to learn Spanish in middle school and high school and college and to keep practicing, it would have been more of a struggle for me to provide culturally competent care in the native language of Spanish to that population. So at Texas Tech Health Science Center, over the past year, we put together a system-wide Spanish language development and cultural development course or task force to reimagine what teaching medical Spanish to all of our trainees that are forward-facing, patient-facing healthcare training workforce programs, and how we might additionally expose these students to the Hispanic culture as well. I think Texas Tech Health Science Center El Paso does an excellent job of their medical students. The month before they start their first year, they immerse them within the El Paso community with some of that goal of helping to begin to introduce Spanish and living on the Texas-Mexico border to that population. But it's very, very much needed.
Yeah, those are great opportunities to expand the ability to be bilingual. The reality is rural Texas is pretty diverse. If you're working in an urban setting, you might be in a suburban community and you may have a more homogeneous population. When you're working in a rural community, you treat the entire community. And most of our rural communities in Texas have a growing Hispanic population, a great growing Latin population. There's often an African-American population in these rural communities. And as Dr. Billings said, his patient population, when I worked as a rural physician, my patient population was a very diverse population. And I would be treating immigrants that have just come to this country in a town of 3,500 folks, or individuals that have been here for generations, but have an ethnic identity. So specifically for the rural environment, clinicians that are in rural areas have to be cognizant and have some cultural awareness because they're going to treat the entire community.
Thank you both. I want to lift up a question that came earlier in the discussion, and I think with what both of your institutions and teams are supporting or driving forward, and also part of your aspirations is it's part of it's the workforce gap, but some of the systemic or community context that keep that as an ongoing need, or in some cases amplify the need, especially with more urbanization and growth. So there are kind of two questions, and I want to in a way combine the two in the interest of time. That Dr. Billings, you talked about the ramp pathway program, and there is another question. So as I said, I'm trying to combine the two in a way. Apart from what you both have already shared, what are things, or if I may say, a checks and balance system that can be in place that we can do a lot in terms of incentivizing, loan repayment, innovation in attracting more workforce to consider opportunities, trainings in rural communities, but part of it is actually retaining them in the rural communities. And there are reasons outside the healthcare setting that probably weigh in. So how do we kind of, and I have appreciated a few things both of you have already alluded, taking again that community construct, Dr. Parsi, with the experiences you are providing your students, to have them a feel of what do we mean when we say serving a rural community, but anything you both want to expand upon for what you have already shared.
I think that our publicly funded academic health centers, we need to be held accountable for producing the workforce that Texas needs, which includes the rural healthcare workforce. I think we have to be very intentional about who we admit into our healthcare training programs, from the associate's degree all the way to the terminal degree. And then we have to be very intentional about where we train them. I think that with my rural bias, I think that there has been, since the Flexner report in 1911, there's been this idea that we centralize and urbanize medical education and medical schools at high resource, highly specialized settings. That produces wonderful science and wonderful specialty medicine, but at the expense of training these healthcare training students in the community setting where most health happens, where most of those social determinants of health or the non-medical drivers of health impact a patient's health outside of that healthcare pillar. So I think that we just need to see not only rural students as an opportunity for solution, and be willing to mentor them and enable them to have the same equitable academic chance as an urban educated and raised student. But we also, I think, need to view rural healthcare training sites, whether they be a critical access hospital, a certified federal rural health clinic, or a federally qualified health center. We have to recognize that those are wonderful community health laboratory environments to train healthcare training students. And these healthcare training students will contribute significantly to the health workforce of that rural community simply by their presence as a healthcare training student. And more of them are likely to stay if they get that exposure and they step into a world that may be foreign to them and understand that it's really a warm, welcoming environment, as Dr. Parsi alluded to in his presentation.
Yeah, I would just echo what Dr. Billings said. And I think there's an opportunity here. In urban settings, we're seeing corporate growth in healthcare and consolidation to large healthcare institutions. I was part of an acquisition and saw how that changed the identity of the healthcare institution I was working for. When you work in a rural community, it is a community. And I think many of our students, nursing, medical students, pharmacy students, dental students, they want to be part of a community, and giving them that opportunity to experience it and then have mentors. And Dr. Billings, I know, has been a leader in trying to identify mentorship for medical students to be linked with physicians and other practitioners in rural settings so they can have a role model to see that it is possible, that you can do it. And it's so fulfilling. We talk about burnout among practitioners, and some of it is because of the disconnect between the patient and the provider. Well, you don't have a disconnect when your neighbor is your patient. You are connected, sometimes whether you want to be or not. So when you work in a rural setting, there is that sense of community and sense of fulfillment that you are serving a community that we really want our students to experience.
Thank you both. I do want to be respectful of our time together, but I want to lift up one more question, and we'll coordinate with both of you to make sure that we speak to the other questions, and we'll be sharing them back with our attendees. But as I said earlier, or alluded, like 5 months, and the Texas legislature will be reconvening in January 2025, and based on the efforts both of you are leading and what you have shared and talked about today, if you had to pick one or two rural health priority issues that both of your institutions would support and would advocate or recommend the legislature's interest and support on, what would that one item be? Or we can expand it to two, since we have a long list of things that need to be addressed.
Yeah, first, I remain hopeful. We can do this. We've got this, and so I think that what creates most generational impact is investing in that rural health workforce, investing in that next generation, whether it be the rural student or the urban student that has a passion and a calling to serve rural Texas and the rural United States. And investing in that will be the force multiplication that our rural health workforce needs.
Of course, I agree with Dr. Billings again, but the other thing is financial viability for our rural healthcare institutions. There needs to be a payment structure where they can survive, and if they survive, they can hire that workforce that Dr. Billings and myself and many others are trying to support grow.
Thank you so much, both of you. Again, as I said, we have about a minute, so I wanted to take this opportunity to close this discussion, but again, share my appreciation on behalf of the TPCC team. Dr. Billings, Dr. Parsi, you both are amazing leaders, and it's not just reassuring, it's actually in a way inspiring that is part of a broader context that allows us to be and serve as your consortium and as a collective voice. So again, gratitude for both of you, and you can count on us as your partners in this pursuit. And given that we talked about legislative session, health policy priorities, for those of you joining us, as I shared earlier, Texas Primary Care Consortium is honored to convene a statewide consensus panel, is a way that we engage with all voices that make up the part of the primary care ecosystem to identify a set of consensus-based priorities that we can present for the legislature to consider and get their support on. And as part of that is ensuring that we are creating forums for all of us to continue having this conversation, but also bring in the elected officials. So save the date, and the registration is actually open. Go on Texas Health Policy Forum. It's on December 5th here in Austin. And we look forward to seeing many of you there and continuing this conversation, and hoping that we will have some wins to report on the next time we reconvene. Dr. Billings, Dr. Parsi, thank you again so much. And for those of you joining us on the webinar, thank you for sharing your time and expertise with us. Please follow us on the consortium and reach out to one of us to find ways we can engage you and your expertise in our shared pursuit. Thank you again.